Good morning, SMA. It's a pleasure to be able to present this information to you. We're talking about evaluating and treating GI bleeding. It's Peter Buck from Connecticut, and here we go. I have no disclosures. The objectives are to discuss the risk factors that lead to GI bleeding, to describe the limitations of colonoscopy, to talk about alarm symptoms, to describe the usefulness of advanced endoscopic techniques, and to recognize the safe use of antiplatelet and anticoagulation medicines after GI bleeding. So let's start with Tina, who is a 19-year-old on doxycycline for acne. Today, in a rush, she swallowed the doxycycline without taking any water whatsoever. And it's a situation I've seen many times in my office. She comes to see you with a small amount of hematemesis and adenophagia. What do you suspect? Before you give the answer, let me show you what it looks like. This is what it can look like. It's a doxycycline actually impacted in the esophagus. And if we would have a picture of this after removal of the capsule, you would see ulcers at both ends of the capsule. So again, it's fairly emergent to get this out and prevent further complications. And this is what happens. It's an esophageal ulceration slash impaction of the doxycycline. Let's now talk about Bob. Age 23, just graduated from college. He promptly went drinking with his friends. Then Bob had 9 episodes of vomiting, followed on the 10th episode by vomiting a cup full of blood. What is happening here? Let me point out to the fact that it is regular vomiting, no vomiting of blood 9 times, and the 10th episode was vomiting a cup full of blood. And this is obviously a Mallory-Weiss tear. This is what it looks like. And again, Mallory-Weiss tear is a small rupture at the lower end of the esophagus caused by pressure. As an additional question, let me ask you this one. If this patient had continued to vomit and then suddenly had shortness of breath, what is that called? That's called a Boerhaave syndrome. And that is a medical emergency that needs to be handled immediately. No endoscopy is indicated. This is a surgical emergency that needs to be approached immediately. So Boerhaave is a surgical emergency. Here's an important one for primary care folks. Can a single low dose of aspirin cause a major GI bleed? The answer is absolutely. We've seen it in years gone by. And I want to make sure that we're all aware that a single dose can cause a major problem. It's not usual, but it certainly can occur. Let's think about naming some risk factors that can lead to GI bleeding. And again, we're all aware of it, but let me put it in a context that will all be very appropriate. Some of these things are important to think about when we're prophylaxing a patient. For instance, a patient who has had previous history of ulcer disease, a patient who has now had previous history of ulcer disease, who is on a combination of aspirin, nonsteroidal, anticoagulant, etc. And let's show you the full list. Age is an important risk factor, chronic illness, and of course the medicines that we talked about just a moment ago. So the other part of this is that if we have a patient who has had a previous history of an ulcer and chronic illness and is on the medicines that we have listed here, they certainly should be on a proton pump inhibitor to prophylax the possibility of GI bleeding. Let's move on from there to think about what is the accuracy of a Hemoccult in detecting a colon cancer. And the accuracy of Hemoccult in detecting colon cancer is extremely low. We're talking about less than 30%. And when we have that kind of thing happening, one of my GI societies has recommended avoiding the use of Hemoccult and moving on to other more specific testing that we will mention in a moment. What causes false positive tests? Well, many of you out there are thinking about the consumption of red meat. Absolutely right. It's the blood within the meat that can cause it. Also, think about the potential of false positive tests is from a nosebleed. We've seen that several times before. Vitamin C can cause it. Horseradish can cause it. Radishes, turnips, or other foods that can cause it as well. Vitamin C, as I said before. Iron does not cause false positive tests, but because the predictive value of a Hemoccult and the diet that's involved, there are additional things that we're looking at, and that's why my society is recommending more advanced testing. So let's look at this. When we're looking at the fecal immunochemical testing, which is pretty much the standard that many folks are using out there, the sensitivity for cancer detection, 79%, specificity, 94%. And when we're looking at the Cologuard testing, as we see on the right in the yellow, we see that the sensitivity is much higher, but the specificity is lower. So we're obviously having some false positive tests out there. And I want to just review that with you for a few moments. So when we're thinking about the testing, first of all, the fecal immunochemical testing is much less expensive than the Cologuard test. Cologuard test runs about $600 and is covered for Medicare patients. There's some HMOs that cover this, but not very many yet at this point. But more importantly than that is if you're thinking about a Cologuard test in an older population, there can be a 10 to 20% false positive test because of methylation that occurs. And when the methylation occurs, this is the kind of patient population that you don't want to have to do a colonoscopy unless you really have to. So be aware that false positive tests happen. And some of my GI societies, until further information is available, is sticking with the fecal immunochemical testing until we have much more information about the Cologuard testing, the multifactorial testing. Let's talk about Maxine, who is a 67-year-old patient who had hematemesis last week. She has a long-standing history of reflux and has not been on steroids and non-steroidals, and does not consume alcohol. Physical exam is unremarkable. H&H is as above. And here's what the endoscopy showed. And clearly that is a Barrett's esophagus. It's the salmon-colored mucosa with edges that come in the lighter appearing mucosa. And Maxine was started on a daily PPI. The biopsy is showing Barrett's, but now there's dysplasia. And dysplasia, as we all know, is an abnormal tissue finding that's not quite normal and is not quite malignancy, but it is a concern for the development of malignancy. This slide is a key element of what we need to think about. So what do you suggest as the next step? Do you suggest repeat endoscopy and biopsy in 6 months, mucosal resection of the Barrett's, radiofrequency ablation, and which is a heat destruction of that area? And what do we think about? Well, many of us grew up with repeating the endoscopy and biopsy in 6 months. And let's look at a little bit more information here. This top part shows what a mucosal resection is, and it's removing a divot. It's using a cap on top of the endoscope and endoscopically removing a divot from the lower end of the esophagus. Radiofrequency ablation is a burning of the area. You can see it down below here. And it is an alternative way of taking care of a diffuse area that has a dysplasia, as we mentioned before. But here is the key of the change that I want you folks to be aware of. Meta-analysis found an 86% reduction in progressing to high-grade dysplasia using this radiofrequency ablation compared with just surveillance. So it's a paradigm shift that I want you all to be aware of, that many gastroenterologists are becoming much more aggressive when they see dysplasia in Barrett's esophagus. So we're avoiding, under many circumstances, that follow-up in a few months and rebiopsying, and being much more aggressive to prevent a malignancy from developing. So what are the causes of lower GI bleeding? We all know that, and we know the percentages, but here's a quick review. And diverticulosis being the major source, and there's a whole bunch of others. Several of these we're going to be talking about in the upcoming slides. Let's now talk about Helen, who, age 75, presented to the emergency room with a massive lower GI bleed and bright red rectal bleeding. You can see the rest of the story. She is hypotensive and tachycardic. You can look at the H&H. She received 4 units of PAC cells. The bleeding stopped. Colonoscopy is negative. And what are the next steps? Well, we need to think about what the next steps are, because again, we'd like to find out what the source of this bleeding is. And when I've done this with groups in the past, there are all kinds of answers that I've gotten, but here is the important answer that we need to think about. 10% of all lower GI bleeds arise from the upper GI tract. And if there was a single test to do as a next step, it would be an endoscopy under these circumstances. It's certainly not something we want to miss given these circumstances. But let's talk about more advanced testing, and we see them right here. So let's say this test endoscopy is negative, and we're particularly concerned about seeing things going on in the small intestine. Obviously, the left upper area is a capsule that is used to evaluate the small intestine. It's a regularly done test. The one in the middle is something you folks may not be familiar with. It's an enteroscope. It's used in some advanced practices to check the small intestine. It can be used antegrade or retrograde. It can be done as an endoscopy, swallowing and going into the small intestine. It can also be done as a colonoscopy, going into the small intestine that way. The tremendous advantage of this is that using an endoscope, we can biopsy the area, and we can also apply therapeutics to the area as well. The non-invasive test in the right side is a MR enterography, and that is a way of checking the small bowel using an MRI. So again, non-invasive, MRI. Invasive is the enteroscope. And when we're thinking about this, what is the complication that may happen when we're using a capsule study? Is there a particular complication that potentially could happen if we're checking out the small intestine? The answer is small intestinal obstruction. If you have a narrowing of the small intestine, the capsule actually can get stuck in that area, and that's one of the things that we need to be aware of. Here's a trick question. Let's think about the answer. What is the best test to screen for colorectal cancer? Look at the answers. And many of you are going to say the answer, colonoscopy. Of course you're right. And colonoscopy is the very best test from my perspective to screen for cancer. The other ones we can consider, but here's the real answer that I want to share with you. And there's always a story that goes along with this. The best test to screen is the test that gets done. Very important. Think about this perspective. If you have a patient and you're saying that they should have a colonoscopy and you send them over to the gastroenterologist, but they really don't want to have a colonoscopy done. They've heard of Aunt Tilly who had a colon perforation when they had a colonoscopy done, or they figured that it's going to take too much time, inconvenient, they can't afford the copay, or 100 other excuses. That test may not be done. And it's obligatory on us to make sure that that screening is done, because we know that there's a sequence of events from no cancer to cancer through a polyp sequence in the vast majority of patients. So if we can get early information, it is the very best that we can do for these patients. So can a Cologuard test be done? Sure, it can be done. It is very useful. Virtual colonoscopy, that's a MRI or a CAT scan of the colon. It usually is not paid for by insurances, but it certainly can be done. There is a capsule study. It's not a very accurate way of checking the colon, but it certainly can be done. But the key here is making sure that the patients have some sort of screening being done. One thing that you've noticed here in this listing, why didn't I include a barium enema? Well, a barium enema and even an air contrast barium enema is not particularly accurate. It has a 40% chance of missing some lesions. So we're not necessarily using a barium enema to do any sort of screening for colorectal cancer anymore. Here's one that I want you to think about at length. When should we stop routine screening colonoscopies? Oftentimes, when I have groups talking about this, there's a lot of controversy. And let's think about the ages. Age 70, age 80, age 85. Well, certainly age 70 is pretty young to stop routine screening colonoscopy. I'm not talking about a follow-up. I'm talking about a first colonoscopy at that age. Here's how we look at it, and here's the perspective. I want to share with you many of the discussions that I've had with my colleagues over the years. So when we're talking about routine screening colonoscopies, the best answer I've heard is that they're pretty functional, even if they're a little bit older, and that we expect that they're going to be living at least 10 more years. There also has to be a limit about the upper age. So the personal criteria that I've used is 82 in men if they're particularly healthy, and 84 in women. Can this vary from practice to practice? Absolutely. There's so many guidelines, it's incredible. However, we want to give patients the benefit of the doubt. Also looking at their overall functional status. You and I have all seen patients age 50, 60 who are in terrible shape because of multiple medical problems. And we've also seen patients in their 90s who are still chopping wood and doing incredible things. Not that I'm recommending any patient in their 90s to have a screening colonoscopy, but you get the idea that we have significant differences in functionality among patients. So again, in around the age 80, 84 is the top limit of what I would think. And here are some online tools that would be particularly helpful for you. Use them. It'll help you make a better decision with regard to what's the upper age limit for patients for colonoscopy. Let's move on to Todd. Todd, age 67. And yes, this is moving on up to the east side with a deluxe apartment in the sky. George Jefferson and Wheezy, age 67, just had a screening colonoscopy done last year by an out-of-town gastroenterologist. The report was normal. However, 2 weeks ago, Todd was found to have a rectal bleed. You got especially concerned when you found a hemoglobin of 9. You appropriately ordered a repeat colonoscopy locally, and the patient was found to have a massive sigmoid cancer. What's happening? Let's move on from there. Well, he has alarm symptoms, rectal bleeding, anemia, but the alarm symptoms include also fever and weight loss. When we have alarm symptoms, these are ways of seeing whether there's something important going on that we really need to be concerned about. So, for instance, alarm symptoms after a routine screening colonoscopy is an opportunity to recheck this patient. So let's say it's the same patient who didn't necessarily have a low hemoglobin hematocrit, and that we were concerned whether there's something else going on. It's the potential. It's the potential for doing an additional test. And the test should be a colonoscopy. And it's also to be making sure that there's nothing else going on. So for instance, I often get this kind of question. A younger individual with a screening colonoscopy, let's say age 55, screening colonoscopy 2 years ago, and now has a drop of blood in the stool 2 years later. Should another colonoscopy be undertaken? Well, alarm symptoms include rectal bleeding, anemia, fever, and weight loss. And if there's no anemia, fever, and weight loss and just rectal bleeding, it's a potential for ordering an additional colonoscopy. Is it obligatory in a younger individual? Absolutely not. Absolutely not. So it gives us the potential for doing testing, and we need to use this test, this consideration of alarm symptoms appropriately. And another example would be a patient who has had irritable bowel syndrome. Irritable bowel syndrome has been worked up and evaluated with testing over the years, but suddenly there's rectal bleeding and or any of these other symptoms happening. Well, if it's irritable bowel and suddenly there's rectal bleeding, it is the potential for doing additional testing like a colonoscopy. Is it obligatory? Not necessarily, but it gives the potential for doing additional testing depending upon clinical circumstances. So when we're talking about our particular patient here, what is this called? It's called interval cancer, and it's a colon cancer diagnosed within a short period of time after a normal screening examination. And let me tell you the personal story. It's happened to me. It's happened to all gastroenterologists over time, because again, there are certain things that we're going to talk about in a few moments that lead to this problem. It makes us feel absolutely terrible, but the whole point here is there is no perfection when it comes to colonoscopy. The rate of interval cancer is probably a statistic close to 1 or 2%, but again, it is extremely, extremely low. Here's why it happens. Poor prep. So the standard of care is a split dose prep, as you are all aware. And here are some other reasons that happen, and this is related to whoever's performing the procedure. Lack of time examining the right colon. Doesn't happen very much these days. Incomplete removal of a polyp. Missed lesions, and that can happen. Think about the three-dimensional perspective of a colon. And we're twisting and turning the colon, and think about coming around corners that small lesions can be missed. Here's the message that I want to share with all of you. Remember what we said before, that there is a sequence of events from no cancer to cancer potentially happening over 10 years. The vast majority of these patients happening in a polyp sequence, a small polyp becoming a larger polyp, becoming even a larger polyp, and becoming a malignancy. The last thing here is very rarely de novo colon cancer occurring without previous polyp. Extremely rare, extremely rare. So, how often are poor preps encountered during colonoscopy? Think about what you would say as an answer: 5%, 15%, or 25%. And the answer is 15%. How can you partner with your GI colleagues to improve this figure? One of the things I want to share with all of you is that one prep does not fit all people. Occasionally, we have patients who go to the bathroom every week or two. That's not the same as a person who goes, and we should not do the same kind of prep for that person as a person who goes to the bathroom 2 or 3 times a day. So it's really important to help customize the prep. Again, with lots of GI facilities right now doing direct colonoscopy, it's really important to make sure that this message comes across to whoever's going to be performing the colonoscopy, which leads me to the second item here, the second bullet point. Some patients need a 2 or even 3-day prep. I know it's a lot to expect from a patient, but it's better to have a 2 or 3-day prep and having success there rather than having a poor prep and having to do it again at a future time. Some patients have trouble taking a liquids diet. Just be aware of that. Take into account comorbidities and ensure the patient is compliant with the prep. Oftentimes, in years gone by, I would get these calls in the middle of the night. I was only able to take part of my prep. I'm vomiting. It's now 2 o'clock in the morning. I've got a colonoscopy now at 6. What are we going to do? It's a little bit late to create a good environment for that particular patient, but this is the kind of information that we need to think about and plan in advance of the preparation. Know your patient, know what they can tolerate, have that discussion with them, and coordinate with the GI team who's going to be doing that colonoscopy. Here's what I want to show you. It's a real important thing that we've discovered in the last few years. If we're thinking about and looking at this typical left colon lesion, it's the typical kind of polyp that we expect to see, a mushroom-like polyp on a fairly large stalk. That's pretty obvious. And that's the lesions that we have thought about in years gone by that are typical of the left colon. Think about this. If you have a large amount of stool in this area, you'll still probably see the tip of this polyp or an edge of the polyp, and you'll probably be able to make the detection and evaluation and treatment of this polyp. Now look at this polyp on the right colon. This is a really subtle polyp, and look how flat this thing is. And let me tell you a story in a GI conference a few years ago. We had several of these polyps projected on the screen by in a national context. And among the gastroenterologists, even gastroenterologists had difficulty making the determination under some of these circumstances because they are so very flat. The whole point here is in the right colon. It is so very important to have a clean colon because you can imagine if there is stool on top of this, it's going to be very easy to miss as opposed to this lesion that we see in the left colon. So this is a key element of how colon cancers can be missed because, again, we talked about that polyp sequence. So you have a flat polyp, as we see on top, developing over years, and then suddenly there's a malignancy. So this is the kind of thing I want you to be aware of. And the message here to all of you is we got to do as best as we can with these patients with their preps. Think about this. Think about this situation, and I'm sure you've heard of it in your practice. You have a single mom who is working 2 jobs, who has a couple of kids at home, who has a colonoscopy that is scheduled. And the colonoscopy that's scheduled, she had to get a babysitter and make all kinds of arrangements. What's the chance that she's going to be coming back for a follow-up procedure in the future if the first one is bad? It's going to be really, really low. So we want to make sure that this is successful the first time around. Know your patient, ensure success, coordinate with the gastroenterologist. Here's a take-home message. Colonoscopy does not prevent all colon cancers. Read the endoscopic report carefully and also be aware of the people performing colonoscopy in your area. And our goal as colonoscopists is to have a 30% polyp detection in males and 20% polyp detection in females. That's the standard of care. Does that mean we're going to find these huge polyps in males or females? No, that means that we're going to find even small polyps that can be removed, and that means that the standard of care has been met in your with your gastroenterologist in your area. Here's how you can protect yourself. Does your practice have an automatic reminder about screening? Patients get shuffled in the system, they move around from area to area, and it's really important that they have that reminder about that screening colonoscopy. Do copays get in the way? I've seen it multiple times in my area where copays can be up to the point of $1,500. And a patient will tell us, no, there's absolutely no way I'm going to be doing copays under those kind of circumstances. We need to make sure that patients get their screening. There are all kinds of ways of making sure that this can happen, including using ambulatory care centers and working our way through that and making sure that the path is clear for our patients to make sure that they have their procedures done. Fred is a 62-year-old patient who had a colonoscopy and polypectomy this morning at another hospital system. He is now in the emergency room with moderate mid-abdominal pain. He tells you that he wouldn't have come in if his wife didn't force him. Doesn't this sound familiar? Physical examination, you can see over here, temperature 99.9, and abdomen was moderately tender, white count 11,000 with a shift to the left. What would you do next? So would you just examine the patient for abdominal tenderness, and if there was no abdominal tenderness, send him home with antispasmodics and a direction to call the GI doctor? A flat and upright x-ray, or a flat and upright x-ray, and if negative, then a CT scan? The answer here is flat and upright x-ray, and if negative, then a CT scan. And the answer is being this aggressive because after a colonoscopy with an elevated white count and a shift to the left with mid-abdominal tenderness, there's always a possibility of a perforation. Doing anything less than that may be a significant problem for the patient, because if there is a perforation that is not addressed in a rapid fashion, there can be significant morbidity and mortality. So again, we are generally very aggressive with following up these patients to make sure a flat and upright is done first, and if negative, then a CT. And flat and upright done first because, again, if there's free air, we know exactly what's happening. And if negative, then the CT, because a CT can show subtle areas that would not be seen otherwise. Bonus points: would it have made any difference if the patient had a colonoscopy without a polypectomy? And the answer is absolutely not. The stretching of a colon can cause a perforation as well. Polypectomy increases that risk, but stretching the colon without a polypectomy, doing a standard colonoscopy, can cause a perforation for sure. Let's talk about Carl, who may be familiar. Look at that face. Is a 55-year-old patient with long-standing history of ulcerative colitis, and it's been stable for 3 years. Here are the medicines. Just to realize that these medicines are the standard kinds of medicines that we use for ulcerative colitis. He just sprained his ankle. And here's a teaching point that we need to think about. Physical and labs are unremarkable. What will you prescribe for the pain and why? So nobody these days is going to be prescribing Tylenol #3 for this pain. That's clear. And I would imagine that 99.9% of you will be saying Tylenol. Well, think about this. And this is the teaching point here. How effective is Tylenol going to be for the pain? And you all know that it's going to be pretty ineffective for pain. And if I would ask you about NSAIDs, many of you would say that NSAIDs are probably going to be exacerbating the situation. Here's the teaching point. The teaching point is Carl has been stable for a long period of time. If you ever have this kind of situation, it's worthwhile to speak to the gastroenterologist, because you may find that a gastroenterologist with this particular patient would feel fairly comfortable in using an NSAID. And in using an NSAID, you'd probably have a much better result for treating the pain. Let's move on to Margaret. Margaret is an 85-year-old who comes to see you for rectal bleeding. She has congestive heart failure and an ejection fraction of 28%. And you can see on the following medicines. Let's talk about how she is doing on the physical exam. She is ill appearing, hypotensive, pulse 96. She's got Rales and pitting edema, and H&H of 7.1 and 20.5. This is a real important teaching point that I want us all to talk about and think about. What we need to think about is how aggressive to be with this particular patient with an ejection fraction of 28%. Think about this perspective. Sometimes I get audiences that just say, well, let's do a colonoscopy, let's do an endoscopy, let's do this test, let's do that test, let's do the next test. Ultimately, when we're dealing with a patient like Margaret, if we find a colon cancer, what are we going to do about it? Is she going to be able to even survive the surgery? And if she survives the surgery, what's going to be happening afterwards? We need to think about the bigger picture when we're thinking about Margaret. Oftentimes, transfusions can be the way to go, or putting this patient on a DNR list. But ultimately, it's a discussion that we have to have at length with the patient and the family to understand how far we need to go. As a professor of mine once told me, one of the most difficult things in medicine is to keep your hands in your pocket and just watch and wait. But again, the point here from Margaret is thinking about not necessarily being aggressive under these circumstances. Let's now talk about Martha, different situation entirely. Martha is a 44-year-old patient with a 3-day history of nausea, vomiting, and profuse diarrhea, diffuse lower abdominal pain, past medical history significant for thrombocytosis, and is on birth control pills for years. And some of you are already thinking, what may be happening? Examination, see that in front of you. The abdominal examination shows a significant left lower quadrant tenderness, but no rebound. There's bright red blood on exam. White count is elevated, again, a shift to the left, and hematocrit is 31. Let me point out this, and this is an edematous sigmoid colon, and over here you can see the edema. This is the lumen, and it already giving us a little bit of the answer about where we are with this patient. So what is the most likely diagnosis? Is it Crohn's disease, ulcerative colitis, diverticulitis, or ischemic colitis? And the answer here is ischemic colitis. Why am I thinking about ischemic colitis? Well, a couple of things in the history and also the X-ray result that we had just seen points to that. The history that the patient had been on has history of thrombocytosis and has been on birth control pills, both of which lead to increased clotting. And the edema that we had seen in the previous slide points to that. Diverticulitis would not be part of that, nor ulcerative colitis or Crohn's. Ischemic colitis is the most likely diagnosis for this patient. And here, the treatment for ischemic colitis, especially in a younger patient, gut rest, IV fluid, give it time, continue to monitor for worsening. The chances of this worsening is very, very, very low in this particular patient. And also the ultimate answer of where we need to be with this patient is certainly she needs to be off of the birth control pills. The thrombocytosis is already enough of a risk factor for future troubles. Let's get her off of the birth control pills, which would prevent some of the further potential problems for her. Let's move on to the next slide. You're doing your buddy a favor and working as a hospitalist for one day. John is a 69-year-old with a placement of a drug-eluting stent just a few weeks ago. He's on clopidogrel and aspirin, and the patient is now admitted with a significant lower GI bleed from a sigmoid diverticulum. And we all know that these drug-eluting stents need to be in combination with clopidogrel and aspirin or something for a lengthy period of time, usually a year, sometimes 2 years. But again, we're at a real significant dilemma for this particular patient, John. So which medicine do we need to stop? Do we need to stop the clopidogrel, the aspirin, or both? And again, among the audiences that I've worked with, many have said to stop both. But I'm going to show you a little bit of an paradigm shift that is eye-opening, and I'm going to give you a story that I've encountered under several circumstances that will change the way that we approach this. So let's look here at the data. The take-home message is recent drug-eluting stent placement creates a high risk of additional clots, and we need to make sure that a patient on dual antiplatelet therapy should lightly continue at least the aspirin. If the clopidogrel is stopped, resume it once hemostasis is achieved, and always coordinate with both cardiologists and gastroenterologists. There have been several circumstances that I've seen in the last couple of years where even if a patient is bleeding, the cardiologist absolutely says it is vitally important that the patient stay on combination medicine because of high risk clots. So the point here is that under most circumstances, we can at least stop the clopidogrel and maintain aspirin, but sometimes, depending upon the clinical cardiological circumstances, both medicines need to be continued. Let's look at Ron, age 78, has a son, Bob, who developed colon cancer at age 45. What would you advise Ron? This is a paradigm shift once again. Ron has a son who developed colon cancer. We don't usually look at it that way, but we're seeing many more young people with colon cancers. And as we talked about before, Ron, age 78, if he's never had a screening colonoscopy and is in reasonable shape, he probably should have one done because, again, it's a higher risk of colon cancer in family members. So Ron should have that colonoscopy if he is in reasonable shape to have one done. Dr. Bob is a 39-year-old emergency room doc who spoke with me recently. It's a true story. He had rectal bleeding. His colleague in the emergency room did an anoscopy and clearly saw blood coming from an internal hemorrhoid. And Dr. Bob asked me the question, should I have a colonoscopy? What do you think I said? I said, absolutely. And here's the answer. Young patients do get colon cancer. Now, in this particular patient, Dr. Bob, yeah, his friend did see a bleeding coming from hemorrhoids, but could there be a second lesion going on? It is always possible. It is always possible. But look at this, and this I think will change some of the way that you approach the younger people who have rectal bleeding. The overall incidence of colorectal cancer has been decreasing in older people. 15% of colon cancers are detected below age 50, and there's been an increase in colon cancer for those who are younger. Oftentimes, it's a much more aggressive cancer, and in fact, some of you may have seen a very controversial article put together by American Cancer Society that screening should no longer be happening at age 50, should be happening at age 45. Don't quite get ready to have your patients screened at age 45. It's not standard of care yet, but it points to the fact that American Cancer Society, as well as many others out there, are concerned about this young adult epidemic of aggressive colon cancers. Let's now move to Sadie, who is a 92-year-old, past medical history significant for atrial fibrillation and a mitral valve repair. CVA 1 year ago on Coumadin, massive lower GI bleed. You can see the vital signs. You see the hematocrit, which was 25. She was transfused and stabilized. Colonoscopy showed an oozing cecal AV malformation, which is a blood vessel. Typical appearance is on the left side, and on the right side is a clip, which was used to clip it and seal it off from preventing it from rebleeding. And when should the Coumadin be restarted? Well, this is also a change in how we approach this situation. In years gone by, we used to wait a period of time, a couple of weeks, sometimes a month under these circumstances, to make sure everything was okay, that would be no further bleeding, but that's changed significantly. Look at this from Witt in the JAMA Internal Medicine 2012. Coumadin restart time depends on the risk of stroke. Timing of therapy depends upon how torrential the bleeding was, and restarting therapy depends upon if there was an endoscopic intervention. And again, these days, we usually do an endoscopic intervention in the form of clips, and clips were not available so many years ago. We used to do cauterization, injections, other things. Clips have been a real boom for us to help prevent further bleeding. And look at the next part of all of this from Witt's study. Here are the details in this particular study. 442 patients with Coumadin and GI bleeding. 260 resumed Coumadin at 14 days. 26 patients had non-life-threatening GI bleeds. 10 patients in the group without Coumadin had recurrent GI bleeds. And in the Coumadin group, 0.4% had a thrombotic event. The non-Coumadin group, 6% had a thrombotic event. The take-home message here from this particular study is be aggressive with restarting the Coumadin. And look at line 2, starting Coumadin at 14 days. There are many of my colleagues, myself included, that may start the Coumadin the following day. Because again, the longer you hold out on Coumadin, the higher the risk of having an embolic event. Finally, let's talk about radiology and massive lower GI bleeding. It's particularly useful for high-risk patients, continuing bleeding, and negative endoscopy and colonoscopy. It's basically clotting the area in sources of bleeding. It's particularly useful in patients who have had torrential GI bleeding, where you can't even see anything with the endoscope, but there's always an upside and a downside. The upside is that hopefully surgery can be avoided, but sometimes there are complications with putting in these coils intravascularly that can cause necrotic areas and worsening of the situation. So again, when this is ever contemplated, surgery backup must be thought about because again, complications can happen. So think about the alarm symptoms that we talked about before, and what do they indicate? So review the slide that has the alarm symptoms, and what do they indicate? It's an opportunity to re-examine the area. The great example that I talked about before was the potential for a patient, let's say with irritable bowel syndrome. And a patient with irritable bowel syndrome should never have rectal bleeding. If they have rectal bleeding, it's an opportunity to check for other things that may be occurring. And the other situation that we talked about is a patient who has had a screening colonoscopy in the past, was negative, and now has rectal bleeding, anemia, etc. It's an opportunity. Is it an obligation? No, but it's an opportunity to check and make sure that there's nothing else going on. Finally, the timing and safe use of antiplatelet and anticoagulation medicine in GI bleeding is dependent on risk of continued GI bleeding, risk of cardiovascular complications, talking about clipping was applied, and bottom line, use sooner rather than later to prevent complications. It's truly been a pleasure discussing this all with you today. Have a wonderful day. Thank you very much.